Hello, everyone. In the name of the National Latino Behavioral Health Association, the National Hispanic and Latino Addiction and Prevention Technology Transfer Centers, we welcome you. My name is Priscila Giamassi, and I am the project coordinator for the National Hispanic and Latino PTTC. Welcome to the second session of a four-part series titled Accelerating Training in Behavioral Health Equity, a learning series for trainees. Dr. Sampilo did an amazing job yesterday. The session was just great. So thank you to our amazing presenter and thank you for the participants. You engaged with us throughout the entire session and you helped us so much. So thank you. We appreciate your participation and we welcome you again. I will be your host for today's session. And before we start our presentation, we will share some information about the training. Here is some information about our grants. You're going to receive a copy of this presentation so you can read the content at your own convenience. Here are some housekeeping items. This session is going to be recorded and archived for future playback. You're going to receive a copy of today's slides. The lines will be muted throughout the entire session so as to minimize background noise. When we get to the Q&A portion of our webinar, you will have the opportunity to ask questions by clicking the Q&A box. And now we'll be more than happy to share your questions to our presenter. We will be asking you to fill out a brief survey at the end of this webinar. The satisfaction evaluation is very important for the work that we do and provides us with the opportunity to improve our training efforts. Closed captioning is available for this event. You need to activate your screen by clicking the live transcript button at the bottom of your screen. Then choose show subtitles. If you have questions, let us know. And a certificate of completion will be sent via email after today's session. We would like to take a moment and reflect on the power of words. We are all prevention leaders in our teams, our community, and our fields. Together, we can use words to create positive change. Here's the Ttc Network Map with information about the addiction, prevention, and mental health technology transfer centers. Each network is comprised of 10 regional centers and 3 national centers, the networking coordinating offices, the National American Indian and Alaska Native TTCs, and the National Hispanic and Latino TTCs. Our centers have a national we are working nationally to take care of the Hispanic and Latino communities and the workforce that provides services to these populations. Please allow us to introduce our parent organization, the National Latino Behavioral Health Association, NALBA. NALBA is a nonprofit and it is located in New Mexico with a mission to influence national behavioral health policy, to eliminate disparities in funding and access to services, and to improve the quality of services and treatment outcomes for Latino populations. Here you can see NALBA's policy priorities, selected capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, Latino legislation to increase the number of behavioral health professionals, funding for co-occurring disorders of alcohol and substance abuse, opioid crisis in the Latino community, and suicide prevention. Now, we would like to take this opportunity to invite you for the 2022 National Latino Behavioral Health Conference, Latino Behavioral Health Equity, Juntos Podemos. It is happening in September 15 and 16 at the Sahara Hotel in Las Vegas, Nevada. This conference will provide a forum for behavioral health professionals from different areas to connect, exchange ideas, and together explore best practices to attend the Hispanic and Latino communities. I'll ask my colleague to share the conference website link on the chat so you can take a look and learn more about this incredible event that we're organizing for our communities. Dr. Sampilo is one of the presenters, so I'm sure you're gonna love to meet with her in person there. So hope to see you there. Next, we just want to introduce you our team. This is the National Hispanic and Latino ATTC staff. We have Dr. Suzy Villalobos serving as the project director. Raquel just started yesterday with us. Welcome again, Raquel. She is working as the co-director for the ATTC. And Anna is our program specialist. On the next slide, you're going to see our PTTC staff. We have Dr. Susie Villalobos one more time, because she's also the project director for the PTTC. I'm working as a project coordinator, and I have also my colleague Christina working as the program specialist of our center. We are truly honored to serve you. Now it's time to introduce Dr. Sampilo. I'm gonna read her bio very quickly. Yesterday I had some issues pronouncing some words, so let's hope that I'm gonna do better today. Please bear with me. Dr. Sampilo is a clinical psychologist who specializes in integrated behavioral health and health disparities among diverse and marginalized populations. She received her doctorate degree in clinical child psychology from the University of Kansas, a master in public health with concentration in social and behavioral aspects of public health from the University of Kansas Medical Center, and an executive certificate in social impact strategy from the University of Pennsylvania, all of which have allowed her to develop extensive experience in prevention, health promotion, and intervention for diverse populations, particularly for the Hispanic and Latino communities. Dr. Sampilo is also well-versed in public policy from her tenure as Health Equity and Cultural Competence Administrator at the state level, where she led the agency's behavioral health equity initiatives and consultant with state agencies on issues of equity and diversity, particularly related to race and ethnicity, immigrant and refugee populations. She's currently a psychologist in the Center for Pediatric Behavioral Health at the Cleveland Clinic, where she works in integrated behavioral health within primary care. She currently serves as the Health Equity and Social Justice Lead for the center and is chair of Diversity, Equity, and Inclusion in the Pediatrics Institute of Cleveland Clinic. She also works with various local, state, regional, and national entities on training and professional development in the areas of health, equity, diversity, and cultural proficiency. Dr. Sampilo, is always a pleasure to learn from you. Yesterday's session was just great, so I'm excited to learn from you again today. Thank you for sharing your knowledge with us. You can feel free to start your presentation now.
Thank you so much, Priscilla. And thank you all again for attending. I'm so happy that you all are here again today for part 2. So I'm going to go ahead and just sort of jump into our presentation. I want to make sure I got my clicker going here. Before we begin, I just want to, again, do my land acknowledgement. So I'm delivering this presentation on the lands of the Erie, Kaskaskia, and Mississauga people. The Erie, Kaskaskia, and Mississauga people are traditional owners of the land upon which Cleveland Clinic Children sits, and that's where I'm located currently. And I wish to honor their enduring presence by acknowledging that history, and then also including that history in our work today. And we will be talking a little bit about more in terms of some of the ideas and concepts behind the traditional land ownership. I also, every time for this presentation, so obviously there's 4 of them, I'm going to include something a little new in the land acknowledgement to help sort of promote acknowledging the history of the traditional lands. So there is a link here, the native -land.ca. It's where you can type in your zip code or type in your area and find out a little bit more about the traditional land upon which you currently sit. So definitely, feel free to use that link and learn a little bit more about the history of your location. So disclosures, no conflicts to disclose. A couple things, just housekeeping things that I want to mention, and Priscilla and my team will make sure that we get some additional information on this towards the end. For the sessions 3 and 4 that are coming up next week, so Monday and Tuesday of next week, we are going to be sending out a new link, and you'll have to actually re-register for those 2 sessions using that link, and it's going to be thrown in the chat, and you'll have access to do that, and we'll give you some time at the end of today to also do that. The reason being, we apologize for the inconvenience, but the reason being is we want to make sessions 3 and 4 a little bit more interactive, because the content really sort of lends itself to being more interactive, more self-reflective, and doing a little bit of interrogation of some of the things that we're going to be talking about. We want folks to be able to do that in smaller groups, but the only way to do that is through basically changing a little bit of the platform that we're using. So you're going to get a link, an email today, but again, we're going to give you some time to do this at the end of today's session as well. You'll re-register for those sessions. As part of your re-registration, they'll also ask you the same poll question that I asked yesterday, which is to identify what level of training or work you're at. So are you a graduate student, intern, post-bac, all of those options. Please make sure that you fill that out or answer that regarding your current status. And the reason that we're doing that is that so that when we do assign breakout rooms for sessions 3 and 4, we keep trainees with them. We keep trainees with other trainees, and we keep licensed professionals or faculty or staff in rooms amongst their peers as well. So we want to make sure that trainees sort of stay within trainee groups, and then faculty and staff sort of stay within more of their peer group as well. So again, we'll give you some time to do that at the end of today's session, but just sort of be on the lookout for that email. If you have friends or colleagues who signed up for this series who are not in attendance today, just share that information with them. Let them know that they'll get an email and that they'll just need to re-register for sessions 3 and 4. Again, apologize for the inconvenience, but we want to make sure that we give you the best quality, best experience that we can, particularly with sessions 3 and 4, as again, the content is a little bit more, it just lends itself to more interaction. All right, I want to just sort of cover a couple questions that I got at the end of session 1 that I didn't get a chance to get to. We will have another Q&A session today. Towards the end of the session, we'll leave the last 15 to 20 minutes available for Q&A. But I also recognize that sometimes there's a lot of questions and we might not get to all of them all at once. So I'm going to try and cover a couple of the ones that I missed today. With that said, for Q&A, definitely we want to make sure that you throw any questions that you have in the chat or the Q&A box. As I sort of present today, Priscilla and team will be monitoring the chat to see if there's anything that they want to ask in the middle of the presentation. I know last session I said wait maybe to the end, but I recognize some of those questions are important to answer in the course of the presentation. I want to make sure your voices are heard. So Priscilla and the staff will be monitoring the chat and the Q&A as we sort of go through. But again, there will be a Q&A session at the end of today's session as well. But just really quickly, I want to make sure that we answer the questions that I didn't get a chance to, so I have them here. Alan had asked, with younger population cohorts, teens, 20s, and 30s, are there higher rates of self-referral and seeking out behavioral health care versus older generations age cohorts? So that was one of the questions I didn't necessarily have an answer to yesterday. And I don't necessarily have an answer to it today, but I did do some research. So I can't find anything related to whether that reduces disparities in terms of accessing mental health or sort of engaging with the mental health care system. But what we do know is that for younger groups, there are certain service delivery systems that are more amenable or more accessible for youth to be able to access, and that's doing its part in terms of closing that gap in terms of access. So, for example, we know that children from marginalized groups are utilizing school-based mental health services or integrated primary care services at a higher rate than traditional mental health services, right? And so in some ways, those service delivery systems are helping to close that gap in terms of access. But it is something that, with younger children, younger individuals, there are other service delivery systems that are helping to, again, close that gap. But that's, again, I don't know if it necessarily is closing the significance of the racial or ethnic disparities gap when it comes to accessing care. But definitely there's more options that are being designed to be delivered and to be more accessible for our marginalized communities, like school-based and integrated behavioral health. So great question, Alan. Tracy asked, what justification, if any, do doctors provide for not prescribing psychotropic medications? Great question, Tracy. So, and I hope you're here today so that I can answer. If not, if either one of you is not on here today, I will send you an email with an answer. But what justification, if any? So I would say that, and again, just to reframe for folks who may not have been here yesterday, we talked a little bit about provider factors as contributing to behavioral health care disparities. And some of those provider factors are differences in quality of care or differences in, for example, prescribing practices. So historically, there's a lot of different factors that sort of play a role. I would say there's not a clear justification per se, but there are a lot of factors that likely play a role in provider behavior in that way. So historically, we know that there has been sort of racial framing when it comes to, or racialized framing when it comes to pain, subjective subjective evaluations of pain, right? Pain is a subjective experience. And so we know that sometimes racialized framing or racial biases may play a role in that. And historically, for example, medical providers have reported considering that Black or African Americans have a different tolerance for pain compared to white Americans. And that was demonstrated more in like the medical literature and things like that in terms of physical pain. But there's psychological pain is also subjective. So when we think about providers' behavior, you definitely have to ask the question of whether racialized framing or racial bias plays a role in that. There's also assumptions, right? So as providers, we may be making assumptions, we may think, BIPOC or communities of color, there's some research to show that they would prefer to utilize outpatient mental health services like psychotherapy first before utilizing psychotropic medications. But again, that's not necessarily true for all individuals, right? And so sometimes we operate with those biases or sort of those assumptions, and maybe in an interaction with a patient assume that they would rather try psychotherapy first, right? So we're not maybe asking the right questions, or maybe exploring all of the different factors that might contribute to their decision or their patient preferences. So I think, to your question, Tracy, what justification? I think not necessarily justification, but all of those different factors sort of play a role. But that's a great question, and something that I think we're going to talk a little bit more about today as well. And how about Alan asked, how about exposure and propensity to be experiencing trauma and adverse childhood events? Where would those fit in for disparities in generational trauma? So definitely, if you remember that, remember the social determinants of mental health framework that Compton and Shin outlined. When we think about sort of oppressions and sort of oppressive systems that sort of, again, we think about like sort of the soil, right? What creates the soil for, a tree to grow or sort of to thrive. We know that within that soil, there are things that sort of make it difficult to thrive in those environments, right? And one of the things that is a byproduct of those oppressions and all of those different unjust and sort of unfair distribution of opportunities is adverse childhood experiences. So that is one of the things that sort of results from sort of those base or sort of those structural factors, right? It's thinking about adverse childhood experiences. In a lot of the research, we know that there are a higher individuals from BIPOC communities report or experience a higher number of adverse childhood experiences. There's some data to suggest that that's particularly noted for Black and Hispanic or Latino communities. There's some research that shows that Asian populations or Asian American populations don't experience ACEs in the same way, or have like a lower actually reporting of ACEs compared to white non-Hispanic individuals. But that data, and again, one of the things we're going to talk about a little bit today is that data, I think, masks disparities, right? The Asian American population is a very heterogeneous group. It's probably the most heterogeneous of all sort of the racial groups. And so there's a lot of hidden disparities within that group. So just interpret that with some caution, if you will. So just when it comes to data or research on Asian Americans, there's often a masking of some of the disparities within Asian subgroups. So just something to keep in mind. But ACEs would sort of fall in that unjust or unfair distribution of opportunities. And then one of the outcomes would be trauma or sort of the experience of trauma, right? Given all of those factors. So that's sort of where they fit in that framework, if you want to think about it that way. Great. So I think we covered the questions. So just going into today's presentation, just some key objectives. We're going to discuss structural and upstream determinants. We're going to use a very concrete example to sort of help send that message home for folks. We're going to contextualize social justice and behavioral health. So discuss like why social justice is important to behavioral health, or sort of why you all are here for this learning series. And then discussion of social justice as a critical component across domains of behavioral health. So we're going to talk about it from the lens of prevention, treatment or intervention, recovery, and then overall healing. All right. So I just want to do some framing before we get into today's presentation, because we are going to talk about oppression. We're going to talk about racism specifically. So discussions of oppression and racism have been emotionally charged. And frankly, the reason they're emotionally charged is because we're sort of socialized not to talk about these issues. That's sort of how we've been historically socialized. But not talking about those issues is problematic because, as you know, I sort of alluded to with the different panels of equality, equity, reality, liberation, we have to talk about the fence and what creates the fence, or what is the fence, are things like oppression and racism. So we have been socialized to maybe not necessarily talk about these issues, but it's important that we do. And that's the only way that we're going to make progress with this. I want to also acknowledge that we also have different experiences with these topics. Our identities have impact and influence on our experience. So we're all coming to the table with different identities, different lived experiences. And as a result, we may experience and or think about oppression and racism differently. And that's okay. What we want to do is try and acknowledge that fact is that we, by virtue of our identities or our experiences, we may have different ideas, but that's what we're sort of all bringing to the table today. And this discussion is sort of to help elevate those discussions moving forward. Today is about recognizing, reducing, and preventing harm. So the reason we're going to talk about oppression and racism is because we don't talk about it, we perpetuate the fence, and we actually cause harm. So today is more about starting to recognize, reduce, and then prevent future harm for communities that have traditionally, historically, and currently and contemporarily continue to be harmed. And we may experience some discomfort when discussing these subjects. That's just a known sort of experience for a lot of individuals, is that when they talk about some of these issues, again, because we've been socialized not to talk about them, they may create feelings of discomfort. I want us to consider discomfort as the price for growth, and that think about growth as leading to opportunity, right? So really thinking about, like growing pains, if you will, for children, their bones actually hurt, their, legs and things actually hurt when they experience growing pains. That's the discomfort they experience. As we grow, as we sort of gain new perspective, gain new learning, gain new understanding, there's also might be some discomfort with that. And that's okay. It's okay to sit in that discomfort and just sort of decide what that discomfort maybe suggests. And maybe that's you growing. Maybe that's you getting opportunities to getting more growth to lead to opportunity. And then I want us to consider how we could be doing things differently, right? What we know is that right now, things aren't quite working the way we want them to, right? Things are not equitable. So we can't keep doing what we've been doing, right? Otherwise, those gaps will continue to widen, they'll continue to be exacerbated. What we know is about the COVID-19 pandemic is it shined a light on disparities and inequities that were always there. It just did it in a very, very direct and frankly way, in a direct way, and a way that you can't ignore, a way that could not be invisible to a lot of people. And then the COVID-19 pandemic also exacerbated some of those disparities and those inequities. So we can't really go back to doing things the way we used to do them because it wasn't working. That's why we're all here today, is because we know it's not quite working. So we have to try and do things differently. And today is sort of, again, just a step in that direction to try and think about things differently and maybe do things a little bit differently. So I want you to pay attention to your own reactions and reflections and about what might be causing them if you do have a strong reaction to anything, and then avoid judging others' experiences and consider your own experiences when we're talking about these issues. All right, so we're going to jump into the content for today. So this is, again, the model put forth by Compton and Shim. And I just want to sort of reorient us to the model, right? So Alan, again, just going back to your question, since we're looking at the actual image right now, the unfair and unjust distribution of opportunity, that would include sort of the effect that it creates, which is adverse childhood experiences. And then when you think about trauma, definitely trauma being a byproduct of a lot of these mechanisms or a lot of these factors. So when you think about adverse mental health outcomes, thinking about trauma within that lens as well, and all of these things as contributing to that trauma. So again, we're really going to focus today on this part, the unfair, unjust distribution of opportunity that really stems from the policies, practices, and norms, the things that are really embedded in the soil. So again, when we think about flourishing, we think about thriving when it comes to plants. And I'll be really honest, I cannot keep a plant alive to save myself. I just can't. It's not within my wheelhouse to keep plants alive. I should just have cacti because I think they require a little bit less maintenance. But using that analogy, because I'm very poor at keeping them alive, I want us to think about that as the metaphor, that for individuals to thrive, for them to flourish, just like a plant, they need the right environment to do that. They need the right conditions. But part of that is also understanding what's already in the soil, right? If we have soil that is not amenable to growing things or not amenable to healthily contributing to the growth and thriving of certain living things, then there's a problem with the soil, right? There's a problem inherently embedded deeply in sort of the starting point. And so for us, I want us to think about how those unfair and unjust opportunities or distribution of opportunities and distribution of resources, if you're not able, or if we have that in place, then all of these different other factors that come into play, they're going to disproportionately impact certain groups or certain groups, particularly marginalized groups, because of sort of their position in the social hierarchy, who we value in this society. We ascribe or we assign value to certain groups more so than others. We advantage some groups by virtue of these policies, practices, and norms, and disadvantage other groups. And again, when we think about the groups that experience disadvantage, it tends to be concentrated disadvantage, meaning disadvantage over time, disadvantage in multitudes, and that's what those communities experience. So I just want to sort of think about this again, thinking about flourishing, thriving. We need the right conditions, we need the right environment, but if those conditions and those environments don't exist, then the result is that something does not flourish, something does not thrive, and in effect is harmed and dies. So when we think about structural factors, structural drivers of inequity, we think about oppression. Structural racism or racism is probably one of the most harmful structural factors that there is, the structural drivers that creates the conditions which then perpetuate inequity. So we're going to talk about racism pretty directly today. I want us to understand the different types of racism, right? So structural, it really refers to sort of the cumulative or compounded effects of factors that systematically disadvantage, I apologize for moving, disadvantage some and disadvantage some communities, particularly BIPOC communities or other marginalized communities, and advantage others. So it's this overarching system of racial bias across institutions in society, sort of what drives the different systems, sort of what drives the different experiences for individuals, right? So again, thinking about the plant analogy, it's what's in the soil, right? It's what creates the base and the foundation for whether or not something is going to be able to thrive. But unfortunately, structural racism is embedded within that soil. So when we think about systemic racism, we're really sort of talking about perpetuated discrimination within a system. That's the way that we're going to use it. And there's a history and basis of racist principles and or discriminatory practices within a system. Sometimes systemic and structural racism are used interchangeably. They're just slightly different in that way. So systemic racism may emphasize like systems, like a healthcare system or a educational system, a judicial system, those kinds of things. And then you think about structural really emphasizes the role of those structures that govern sort of how those systems work, talking about policies, institutional practices, and entrenched norms that really sort of create the system scaffolding. So that's sort of how we're differentiating them. Some people think of systemic racism as sort of more of the overarching theme. For our definition and purposes, we're going to talk about structural and systemic. And where we're really talking about systemic, we're talking about systems in themselves or individually. So what we know is sort of when we think about, we saw this slide yesterday as well. When we think about the root causes of inequity, again, you're thinking about a top-down approach, thinking about those structural inequities like racism, which is a driver of those, social determinants of health that then have an impact on social determinants of health, or the distribution or allocation of social determinants of health, or the quality of those social determinants of health. Because we think about social determinants of health, we really only talk about social determinants of health when we're talking about it in the context of adverse health outcomes, right? We really don't talk about social determinants of health necessarily from like everyone's healthy, so these are the social determinants of health that help create their healthy status. It's more about what is missing or what is absent or what is not sufficient when it comes to social determinants of health. So sometimes people call them the social determinants of poor health, because that's really how we tend to talk about social determinants of health, because it's usually in reference to individuals who are experiencing poor health outcomes. But it's because of that unfair and unjust distribution within social determinants of health that is driven by structural inequities. And as a result of that, you have your health inequities that sort of are the product, and then that leads to health disparities, which is sort of what you see day to day. So we're really going to consider an example. So I'm going to walk you through an example of how structural racism from the very beginning of this particular example, we're going to talk about like ownership of land, so property ownership, wealth accumulation, and how it sort of filters down. So just bear with me. We're going to kind of go through this example together. So we're going to talk about Washington, D.C. One, because it's basically where I was raised and I'm familiar with Washington, D.C. and sort of the history of Washington, D.C. I grew up right on the southeast corner of Washington, D.C., basically on the border between Southeast D.C. and Prince George's County in Maryland. And so just kind of give you that lens of my perspective of where it's coming from, and so why I've chosen to discuss Washington, D.C. The geographic makeup and the demographic makeup of DC has a really interesting history. So one of the things is that there's been a history for DC. If you look into the history of basically housing and discrimination within DC, there was a history of racially restrictive deed covenants that basically allowed certain individuals or certain people of demographic characteristics, white folks, basically to own property in certain parts of Washington, D.C., and excluded Black, Jewish, other individuals from owning property. And these racially restrictive deeds could be based on one piece of property, so one land or one piece of property ownership, or it could have been an agreement that individuals within a community or a block sort of entered into. So you could have basically cut off Black, Jewish, or other individuals from entering a whole neighborhood or a whole community. So, and these covenants were governed to those who could purchase or occupy buildings, right? So again, basically restricted property ownership or living in certain areas of Washington, D.C. And they were basically a response to the migration of the African Americans from like the rural South to cities all across the North. So that's what Washington, D.C. sort of did. These covenants were written by the original developers of some blocks. So even like the blocks near what is now like Howard University, so the historically Black college, Howard University, were also included in those racially restrictive covenants as well. The first map on your far left of this slide is sort of the early part of the 20th century when those racially restrictive covenants were in place and were not deemed yet unconstitutional. So that's the map of sort of the demographic makeup of Washington, D.C. The Black individuals are in those darker shaded regions. White individuals are sort of reflected in the rest of Washington, D.C. So as you see, early part of the 20th century, fewer individuals of Black background who were in Washington, D.C. We look now on the second map. This is after the racially restrictive covenants were deemed unconstitutional in 1948. So they were nullified by the court. And then we had an influx or an increase in Black ownership and Black residential ownership within Washington, D.C. And now you see an influx, sort of, this is the 1970s-ish image of Washington, D.C. And this is sort of at the peak of Black and African-American residents in Washington, D.C. And your map now to the right, furthest right along the slide, is now Washington, D.C. within the 2010s. Blue is white, non-Hispanic individuals. Pink are Black African-American individuals. And then green are your Latinx and Hispanic individuals who have moved into Washington, D.C. And you might be wondering, well, why is there now, after the height of the Black community in Washington, D.C. in the 1970s, early 1980s, what has caused sort of this shift over the last several years. And basically back in 2010, they sort of had this plan to increase and attract more people to Washington, D.C. And what they did was there was a lot of funds that were invested into historically Black neighborhoods within Washington, D.C. And even in historically white neighborhoods as well. But as a result, the Black population actually declined in Washington, D.C. and the white population actually increased. So much so that even in communities that surround like Howard University, around like 2000 to 2010, those communities, again, surrounding a historically Black university, were actually considered some of the most quote unquote whitened cities or areas within the whole United States. So again, sort of this interest in attracting individuals, but maybe doing it in a way that also has caused the Black population to drop and the white population to increase. So you see that Black individuals are sort of concentrated on the southeast side of Washington, D.C., again, sort of where I grew up. But this is sort of the history and the legacy of those racially restrictive covenants. And it's something that's still playing out because, again, that map on the far right is from 2010. And so if you're interested in learning more about basically segregation in Washington, D.C., you can check out Prologue DC 2022. They have this fantastic overview of sort of the history of Washington, D.C. and the legacy of those racially restrictive covenants. So when we think about racially restrictive covenants, still think Washington, D.C. We're going to keep talking about Washington, D.C. in just a second. That's the soil, right? Those racially restrictive covenants, the soil, that then impacts socioeconomic status and opportunities for accruing wealth, which is also in this image, right? The discrimination inherent within that, also tied to unfair and unjust distribution of opportunity. And you can see how then this plays out over time, right? So then you have higher rates of adverse childhood experiences. You might have more needs concentrated in certain areas for housing, transportation, food, and healthcare, because certain areas are disinvested in versus other areas that are invested in. And you can kind of see how this potentially has a negative impact from top or from bottom up. So again, think Washington, D.C. I promise we're going to get back to that. Social vulnerability. So social vulnerability is basically the susceptibility of social groups to adverse impacts of like natural disasters. Basically, it was coined in public health to really help planners, if you will, identify which communities are going to be most at risk if there's a disaster. So think of COVID-19, for example. It can be a man-made disaster. It could be an illness. It could be some sort of natural disaster, but basically was developed sort of to help public health planners identify what are the communities that are going to need the most supports in order to survive or order to recover after some sort of disaster. So basically refers to the resilience of communities, that when confronted with external stresses on human health, stresses such as natural or human-made disasters or disease outbreaks. So there's a number of factors that really sort of go into the social vulnerability index, which we're going to get to in a second. But again, the goal of social vulnerability is really to help emergency response planners and health departments and such really sort of just identify who's going to be most at need in the midst of a disaster. So these are the different components that sort of go into the social vulnerability index. So when we think about poverty, we're really thinking about the percent of the population that lives below the federal poverty level. When we're thinking about unemployment, it's basically looking at the percentage of individuals age 16 and over who are unemployed currently. Per capita income, sort of self-explanatory. Education, the percent of individuals 25 and older without a high school diploma is sort of the risk, if you will, associated with education. And then health insurance status is percent of individuals less than 65 without insurance. Household composition, looking at, how many households have someone over the age of 65, under the age of 18, so 17 and under, over the age of 5, who also have a diagnosed disability, and then individuals who live or reside in single parent households. When we think about minority status, we're looking at the percent of the population that are Hispanic or a non-white race. And then individuals, or the percent of individuals over the age of 5 who have limited English proficiency within a household. When we're looking at housing type and transportation, we're looking at sort of multi-unit structures, issues of crowding, mobile homes, no vehicle, or the percent of households without a vehicle, and then individuals who live in group quarters, living in group settings, basically. So these are the different factors that go into social vulnerability. Now, why we're going to get back to DC is on your left is the social vulnerability map of Washington, D.C. The darker shades of blue indicate the areas that have a higher social vulnerability, meaning they are most at risk. Those communities are most at risk to adverse impacts from a disaster, and they're most at risk for challenges related to recovery. That is the map on the left. The map on the right is also Washington, D.C. This is basically based on percentage or residents reporting having poor mental health days for more than 14 consecutive days. And in communities that are darker red or darker orange, maybe some mix between red and orange, but the darker shaded areas are the communities or the census tracts that have more individuals reporting poor mental health days over the last 14 days. So the burden of mental health is not evenly distributed in Washington, D.C. It is predominantly in Ward 7 and 8. Ward 7 and 8 are your southeast portions of DC. Your northwest portions of DC, where like Georgetown University, for example, is located, larger population of white individuals in that community. The majority of the folks in that southeast corner, Ward 7 and 8, are Black, they're African American. So you see how over time, we just looked at a lot of different maps of Washington, D.C., and you see how the risk and the adverse outcomes they dovetail off one another, right? These heat maps, if you will, they look very similar. The darker shades are always in Ward 7 and 8. And the reason for that stems from the structural racism, the systemic racism, and barring Black and African American to basically disperse throughout Washington, D.C. And then for some of those neighborhoods to be disinvested in, basically white flight, if you will, cause some of those neighborhoods to be disinvested in such that we have these significant disparities when it comes to Ward 7 and 8. And it's not limited to mental health, despite that's the focus of obviously of our presentation today. But in terms of chronic disease, physical disability, all of those things, the risk tends to be concentrated in Ward 7 and 8. So again, thinking about sort of the social determinants of mental health, The poor mental health days over the last 14 days, that's just the outcome, right? That's just like sort of what we're seeing, but it's tied to all of these factors. It's tied to all of that, which is sort of represented in all of those maps when you think about it, right? Social vulnerability really sort of gets at some of those things here in the middle when it comes to the leaves of the tree. And then the outcomes are really what we're talking about in terms of that one map in terms of poor mental health days. So you can see how all of these concepts are tied together, right? We cannot differentiate or we cannot take out mental health from structural racism. It is tied, highly tied, and it's causative. It's a root cause of some of the disparities that we see in mental health. So we're going to talk about the other forms of racism. So institutional would be your discriminatory practices within organizations. They reference the policies, the procedures, and practices that often disadvantage our BIPOC communities or other marginalized identities or communities with marginalized identities. Interpersonal racism, obviously discriminatory behavior occurring between individuals. The expression of beliefs via words or actions and interactions with others. But I think it's important to note with interpersonal racism, it's not always as overt as it seems, right? When we see like overt acts of interpersonal racism where someone is visibly or openly biased, racist towards another group, right? It can also be that racism comes out, racial biases come out in those interpersonal interactions, including provider interactions, which we'll get to in just a second. And then obviously individual racism or personal beliefs, feelings, ideas that individuals have about racial groups that influence their interaction. So looking at the individual part of the interpersonal interaction. So as one individual, what beliefs or values or ideas do you have about another racial group? Okay. So we talked a lot about like structural factors just right now. Now I want to sort of talk about the influence of racism and racial bias on these other factors, right? This is also a slide from yesterday. So when we think about individual factors, when we think about racism, I would think about this as sort of internalized racism, right? Sort of the idea that individuals who have experienced systemic, historical, ongoing racism may internalize some of the messaging and the unfortunate messages that are conveyed through those racist experiences. And so thinking about it from an individual lens and how that might play a role in mental health access, seeking out mental health care and experiences with the mental health care system. Provider and clinician factors, we talked a little bit about that, how that plays out a role. Racial biases may play a role in selection and interpretation of tests or measures that we use to assess an individual, how we screen an individual. It definitely impacts treatment planning, as I mentioned in response to Tracy's question, how we plan treatment for individuals. If racial bias is present, that may change or alter our treatment planning. It may change and alter whether or not we prescribe psychotropic medications. There's a lot of different things where, in terms of the provider and clinician factors, we have to be attentive. We have to be attentive to some of these things. And again, it may not be overt acts of racism, obviously, but does racial bias play a role in your professional behaviors, your practice behaviors? This can also come out in just lack of competence, right? So, or lack of cultural competence, lack of understanding how symptoms may manifest or present differently across individuals from different demographic groups, right? So again, just sort of thinking about how racial bias can impact or influence our provider behavior. And then your systemic and institutional factors. So again, thinking about your system. Dr. Kamara Jones, for those of you who are familiar with her, she's fantastic. If you have not Googled Dr. Kamara Jones, please Google her, or better yet, YouTube her. She has fantastic recorded webinars and sessions on YouTube. But Dr. Kamara Jones asks a very key question. She asks people to ask a very key question. She'll ask them to ask how racism is operating here, for people to really think about that. Like within your own clinic, within your own institution, how is racism operating here? And that's a really contemplative question, right? Because racism likely is operating in some way. Again, it may not be overt, but there's likely a way that racism is somewhat operating within your setting, within your clinic. And so when you think about that from a systemic standpoint or institutional standpoint, it's asking sort of a larger world view in terms of those systems. Where is racism operating here? And do we notice it? Do we pay attention to it? Are we acknowledging it? Or are we sort of just going with like, hey, this is how it's always done, so we just keep doing the same thing over and over again? part of what I asked you today was to try and think about how to do things differently. And part of what doing differently is just asking that question and actually reflecting on some of those things. And we're going to talk a lot about reflection. Dr. Kamara Jones. Yes, Priscilla just put it in. Thank you, Priscilla. But really thinking about that idea, right? Can we start to really think, right? We won't see things we don't pay attention to. If we're not looking for them, we're not going to see them necessarily, right? But it's important that we do. It's important that we start to ask these questions so that we can be aware and recognize that the influence of racist practices or discriminatory practices are still present, right? They're still present, and there's still things that we need to address, right? And I saw someone actually mentioned gentrification. So yes, that's exactly what the right side of DC was, is gentrification. When you think about what is sort of occurring. And let me be very honest, there are efforts to try and expand and increase and attract new residents that are actively, I think, thinking about gentrification as they try and plan for that. But then there are still, unfortunately, the byproduct still can be gentrification. And the byproduct for some of the planning, some of the efforts may not be as active in terms of thinking about gentrifying a community and pushing out members of the community. And that's something to consider. And again, that's something very near and dear to my heart. My family lives in a certain place on the Southeast area. They've been approached about basically being bought out of their property with a certain price that wouldn't allow them to live in an area that they would want to live in. So like it doesn't really match, but just sort of thinking about sort of the impacts of gentrification, right? That your property is very valuable. We might need it to, again, publicly institute and use public funds to sort of build up this particular area of the community. But with that said, you're displacing some individuals, and there's not a plan for those individuals to stay within their communities, right? Then that's gentrification, right? You can expand and you can increase residents into your area. You can attract more residents into your area, and you can do it potentially in a way that doesn't gentrify the community, but you have to be very thoughtful and very planful about that. And I think historically, that just hasn't been the plan. It's been investment and displacement sort of has been the plan. And again, I'm not part of like the government of DC or in any kind of way, so I don't exactly know all of the details that goes into their planning. But I think there is, questions about gentrification. And there also have been, I've heard, really like good discussions about doing this in a responsible way that doesn't necessarily gentrify the community. All right. So we talked about systemic and institutional factors. So we actually had a study, Gans and colleagues actually, they actually asked folks, well, let me caveat to the study. I'll get to that in a second. But they did actually ask what they called key stakeholders about sort of barriers and facilitators to mental health treatment for residents in Ward 7 and 8. They identified different factors. They mostly focused on barriers, but then they also, based on the responses, identified some facilitators. So they really sought to really understand, like, what are the barriers to mental health utilization among residents in Ward 7 and 8. And their study was basically semi-structured interviews with who they identified as key informants who lived or spent a lot of time in Ward 7 or 8. Here's the disclaimer. They did not necessarily ask residents. These are key informants. So some of them may have lived in Washington, D.C., some did not. And they basically is a self-selected group, right? So these are individuals who are already willing to sort of talk about mental health versus maybe some of the residents who may be less comfortable talking about mental health to really talk about barriers, right? So again, let's take this study with again, a critical eye in terms of what are the limitations. But in terms of some of the barriers that emerged, society level factors, poverty, again, tie it back to structural racism and the lack of accumulation of wealth over time, right? The biggest driver or the biggest way to gain wealth or accumulate wealth is through property ownership. If you are forbidden or prohibited from owning property, then you have a longer history of not being able to accumulate wealth. And even if you are able to own property now, which obviously anyone can, you still had several years, decades where you were unable to accumulate that wealth, right? So that gap just gets bigger. There's also community level factors, access issues. So again, we talked a little bit about the difficulty accessing care. If you think about, again, Ward 7 and 8, currently, greatest mental health need, by far, wards with the fewest providers, right? So need doesn't quite meet access and resources, right? They're doing a lot, I think, in DC to try and address that for certain. And I do know, I'm aware of a lot of efforts, and they're doing a great job of trying to address some of these things through, you know, the local Children's National Hospital. There's some other healthcare organizations who are working. The schools are also trying to prioritize mental health as well. So there's a lot of efforts that are underway, but I do think it's still important to note that there's fewer providers within Ward 7 and 8, which means that if you have mental health needs, you might have to leave Ward 7 and 8 to access services for your needs, and or, you know, again, with some of the programming that's developing, I think they're working on bringing in more mental health services into the community. But again, we're sort of still working with a gap there. And then just stigma, widely associated as a community level factor. So they also mentioned sort of the model of mental health care as being a barrier, if you will, sort of the model of mental health care just generally not fitting the needs of who the key informants identified as needs for that community. They did say a facilitator would be patient-centered care. So if patients really had sort of ownership over their own care and really could guide their care, that would be a facilitator potentially. And then in terms of individual and interpersonal factors, a disconnect between symptoms and treatment among providers, fear and mistrust of the medical system, obviously rooted in historical racism within medicine, and then facilitators being social and familial support. And then what they mean by triggering events is something like if they experience something like really positive or really or identified early, then that sort of triggers sort of the entry into like discussing mental health. So sort of talking about triggering events with a misnomer, like trigger in this way is not a negative thing. But just sort of thinking about these barriers identified by, again, key informants within Ward 7 and 8. With that said, limitations because it wasn't necessarily residents themselves. And they're very honest about that. And one of the future directions is to really talk with residents, including residents who may not be comfortable talking about mental health, to really get a better understanding of what are the barriers. But as you can see from, you know, we'll go backwards for just a second, for the society and community level factors, as well as the provider and individual and interpersonal factors, all of these have root in that social determinants of mental health model in some ways, or have root or are things that we need to think about when it comes to the role of racism and racial bias. So when we think about inequity, and again, just sort of level setting again around definitions and words. Inequity is the difference resulting from systemic, avoidable, unfair, unjust, and thereby preventable barriers that limit or constrain opportunity for individuals to reach their full potential for health, right? And again, just like I mentioned yesterday, I'm going to highlight that theme of avoidable, preventable, and unjust to really sort of emphasize that it's our responsibility and our role and our obligations as helping professionals to try and move the needle in certain ways, right? And even if that's just you as an individual, you're also more intentional about your work in this space too. So with that, we're going to do a little bit of interactive in the chat. I'm going to try and monitor as much as I can, but I want to know what you think when the word social justice comes to mind. So just generally, what words, thoughts, or ideas come to mind when you think of social justice? So definitely throw them in the chat. I will do my best to monitor said chat as we talk. But I'd like to sort of just get ideas. I see advocacy. I see words like advocacy. Perfect. What else kind of jumps out at you? Equality, vulnerability, fairness, allyship, fighting the system, equal opportunities, unfortunate, bravery, empowerment, redistribution, opportunities, so much. So support, accountability. Thank you so much for interacting here. Rebuilding communities, absolutely. Reform, absolutely. So these are just some of the ideas. Advocacy, I've seen that a couple of times. The disruption of the status quo, absolutely. You're going to hear me say a lot, sessions 3 and 4. The word reimagine is going to come up a lot. And that's why, that we really need to disrupt that status quo. Equity and support. Absolutely, right? So thank you all for participating. I just wanted to kind of get a glance at your ideas regarding what social justice is generally. So these are a lot of the words that tend to come up when we think about social justice, both in terms of what are barriers to social justice, what drives the need for social justice, like things like prejudice, sexism, oppression, and then also things like ally, privilege, ableism, all of those things that sort of drive why we need social justice. And then, as I mentioned, things like ally, that naming, multiracial, things that sort of lend itself to the ideas that you all have put in the chat. I see privileges, justice, trust, navigating systems of care. Fantastic. So we're going to talk a little bit about social justice and then contextualize it in behavioral health. So social justice started off as a philosophical ideal, right? And it really was sort of born with these principles in mind. Some people will say there's 5 principles, one including diversity. For the most part, 4 principles of social justice is sort of what the majority of people sort of ascribe to. But when we talk about access, we're really talking about access to resources, right? A just society depends on access to essentials like food, transportation, housing, those things. Remember, social determinants of health, also there too. Equity means that we provide equitable resources that focus on specific needs for individuals and communities so that they can obtain an equal outcome. Equity also takes into account the role and the effect of discrimination. When we think about rights, it's basically protecting and valuing human rights, right? So when a society is just, it values human rights equally. Human rights are inherent to all individuals, so obviously we all are entitled to our rights, regardless of background, sociodemographic characteristics whatsoever. And what we know about societies is when we equally value people's rights and we honor and we respect people's rights, that society can flourish and thrive. When it comes to participation, this basically is ensuring that everyone has an opportunity to have an active voice in the policies that govern their day-to-day. So you have the capacity and the ability to participate in a system. So in like the system that creates policies, you have those opportunities, right? You can have your voice heard. And what's really important when we think about participation is we have to think about whose voices are being heard, right? So participation grants sort of that principle of social justice, grants that all individuals should have the opportunity to have their voice heard. That includes the voices of marginalized communities that are traditionally shut off or cut off from some of those discussions that guide policymaking, right? So you have to ask like whose voices are being heard. And the answer should be everyone has the opportunity to have their voice heard, particularly those who traditionally, historically haven't had the chance to speak. So those are the principles when we talk about social justice. But what is social justice? You know, aside from the principles, what is broadly social justice? So I kind of like these definitions that were put forth. The goal of social justice is full and equitable participation of people from all social identity groups in a society that is mutually shaped to meet their needs, right? Mutually shaped to meet their needs, meaning we address and we acknowledge that where people's needs are, what they are, and then have a society that can respond and address those. And the vision for social justice is a world in which the distribution of resources is equitable and ecologically sustainable, and all members are physically and psychologically safe and secure, recognized and treated with respect. I think one of the key words here is obviously safe and secure. So we want folks to not only be physically secure, but also psychologically safe and secure, which is really critical when it comes to thinking about oppression, right? The isms, right? If a society is governed by isms or sort of, we have the isms that sort of make up the soil or sort of infiltrate the soil, then not everyone likely feels equally physically and psychologically secure. The other really key point in this definition is ecologically sustainable, right? So we allocate resources to try and promote equity, right? But one of the things that we don't think about is how do we sustain that, right? And part of sustaining that is eventually deconstructing and dismantling the fence, right? Then we don't need the boxes. But until that is the case, and again, we're very far from that, we have to ensure that the allocation of resources based on needs of individuals is something that we can sustain, because it's the worst thing that you can do is give folks assistance and support and then have to pull it away, right? And they don't, and now they still aren't able to achieve the same opportunities or same outcomes as other individuals. So we have to think about how do we distribute resources or distribute supports and help in a way that is sustainable for that individual to be able to meet that same outcome as others. So what does that require? Well, that really requires confronting the ideological frameworks, the historical legacies, and institutional patterns and practices that structure social relations unequally, so that some groups are advantaged at the expense of other groups that are marginalized, right? So when we think about systems and structures, you think about design, right? The systems and structures were not designed to be equal. They were designed in a way that either took into account certain groups or certain perspectives, and by virtue of that, disadvantage other groups, right? They were built so that some folks could be in a position of power and some folks would not have that same power, right? And that is sort of what we need to deconstruct, right? It's sort of that idea that we don't need to maintain the status quo. There doesn't have to be power within these systems and structures. That power can be equitably distributed, but that means that some folks who traditionally have to have power withdrawn. And that's, frankly, if you talk to individuals who do work in this space, that's always the biggest challenge, is the giving up of power. And for some reason, well, not for some reason, but for obvious reasons, that is hard for folks to do, is to give up power. But that's really what it's going to require, a redistribution, if you will, of power, right? So when we think about social justice, now I want you to think about it when it comes to mental or behavioral health. And why do you think it's important for mental or behavioral health? So now I want you to throw that in the chat again and use the chat to sort of explain and what your thoughts are. So like when it comes to mental and behavioral health, or behavioral health broadly, why is social justice important? Or what do you think of when you think of social justice in behavioral health? What comes to mind? What images does that conjure up for you? I see justice, hope, great, great, great. We're going to actually talk a little bit about hope in just a little bit. Needed for so many to deal with traumas, access, healing, having needs met. People need to feel safe and seen. Future social equality, fairness, access. Everyone's doing fantastic, participating through the chat. I really appreciate it. Individuals who are diagnosed not being arrested, absolutely. Equality, accessing services, cultural sensitivity, having equal access and not feeling stigmatized, protecting mental health status. Awesome. Fantastic. Acceptance and understanding, a diverse team for diverse populations. Fantastic. And equal access to services and providers. Fantastic. I mean, you all are doing a fantastic job of identifying, just a really great job of really even thinking about what this would conjure up for you when we think about it in the behavioral health world. And providing support to marginalized groups. Absolutely. Wonderful. All right. So when we think about why social justice, which a lot of you have already alluded to, and I see culturally competent mental health professionals. Absolutely. Yep. Why social justice when we think about behavioral health? Well, as that one quote, and again, I'm going to emphasize those words, as it sort of elucidated that inequalities in health are unfair. They're avoidable. And by reasonable social action are also preventable. So what I mean by reasonable social action, meaning is that there's a collective will. There's a will of the people. There's a will of the communities to say like, yes, these are unfair and avoidable. And as a result, we should be doing things to make this fair, to make this a fairer and more just distribution of opportunities for individuals so that they can achieve their full potential for health, right? And so by taking reasonable social action, we might actually be able to prevent those inequalities. But that requires that collective will. That in general, society should work to ensure that every individual has the capability to be as healthy as possible. That includes mental health, right? So we create circumstances, environments, right? We create soil that allows for everybody to thrive. That's really what the society, what we as a society should be aiming for. And remember sort of that one image of healthy people, healthy by the Bay Area, folks in the Bay Area, it's healthy people, healthy community, healthy society. There's something I'm missing in there. There's one other level in there. But it's that whole idea is that we can't have healthy individuals without creating a healthy society. And a healthy society starts with justice, right? And again, I want to be very clear. We are not close to dismantling that fence, right? So we have to be working towards harm reduction, which is what equity is meant to do. We have to be pushing for equity and harm reduction while also thinking about justice and liberation, right? That they're not mutually exclusive, that we can do one while also aiming for the other. It doesn't have to be all or nothing. And it really can't be. We have to focus on harm reduction because there are active communities of ours, there are active groups that are experiencing harm day in and day out. And so we have to be working towards equity while also understanding that at the end goal isn't necessarily equity, but it's rather justice and liberation. And in order for societies to really promote that all individuals can be as healthy as possible, we have to ensure that every individual has the same opportunity for access, use of care, and quality of care. And again, that also includes mental health care. So ensuring that every individual has that same opportunity. So when we think about social justice in the context of the domains of behavioral health, really when we're talking about prevention, treatment, recovery, and healing, I'm going to go through these individually, and then we'll sort of be at time for questions. But when we think about prevention, really, if you think back to the social determinants of mental health, prevention really starts with how do we address what's in the soil, right? You can't magically make a plant thrive if you don't address what's causing it to maybe wilt, if you will, right? And so the idea about prevention, and frankly, we know that a lot of our marginalized communities don't have the access to mental health care in an equitable manner. They don't utilize the mental health care because there are barriers that are sort of there are a multitude of barriers that they experience or that they face in terms of equitable access to, again, quality care and high standards for care. So we know that. We know that it's going to take a lot of work to address the disparities in access there, those behavioral health care disparities. And so one of the things is that focusing for marginalized groups also on just eliminating or preventing the need for mental health care is important. But in doing so, in order to help individuals thrive so that they don't necessarily need mental health services, we have to focus on prevention. And so for a lot of individuals in sort of the population health space, prevention is really where social justice needs to have its biggest sort of thumbprint. Because if we can prevent suffering among individuals or groups who are already experiencing a high level of suffering, that's really going to help close that gap, right? So really sort of thinking about how do we build social justice into prevention programming. And that includes not only prevention of like mental health issues, but also behavioral health conditions. So whether that's substance use or whether that's poor sleep quality, which we know has a big impact on physical and mental health, whether that is physical activity, right? Thinking about prevention in more of a within social justice orientation to it. So we think about treatment. We've already talked a lot about the different facets or the different aspects that can potentially impact quality of treatment and use of treatment. And so that really means that when we think about certain groups, we know that they have lower rates of treatment engagement, treatment access, treatment engagement, and treatment retention, so staying in treatment. And really sort of thinking about how can we utilize the social justice orientation or the social justice lens to really think about creating treatment systems or treatment delivery processes that are more responsive and more responsive to the needs of those individual groups. So we build and we construct systems that we think work generally for most individuals, but really we should be building and constructing treatment processes and protocols and procedures that really meet the needs of those who have the greatest need, and then work up from there, right? If we can reach the people who we're having the hardest time reaching, then in theory, the system will work for everybody else. But we don't necessarily build our treatment protocols and processes that way. We also don't necessarily have as much research on what is effective treatment. And in addition to that, for marginalized communities, we have some research, but it's not as extensive as sort of research that's really centered and or sort of born from more of a white non-Hispanic majority. So it's really important to sort of think about our work in terms of exploring what are the most effective treatments. The other thing we think about treatment is we really do have to start thinking about how do we respect and acknowledge the role of traditional medicine for a lot of our communities, right? I think in the past, historically, we've sort of said, almost looked at traditional medicine as something that was not desirable, right? When in reality, it really serves as a valuable treatment option and or adjunct to treatment with our traditional sort of therapeutic approaches. So really sort of taking a different lens and a different spin on treatment. When we think about recovery, recovery is really, SAMHSA's put forth sort of a definition of recovery. And it's really talking about the ability for individuals to improve their health and wellness broadly, live a self-directed life, and then strive to achieve their full potential. Can't really do any of those things, again, if you don't address the soil, right? We're going to keep coming back to that idea. We're going to keep addressing the soil and addressing the things that sprout out from the soil. And while we know, and while we focused on recovery being very patient-driven or being very patient-oriented, right? It's the needs of that individual. And we have focused recovery efforts on those, and recovery programming really does sort of center the individual. We know that we still have to consider the social ecology and the environment for that individual, right? To strive to achieve their full potential, again, you can only strive to achieve your full potential, you can reach your full potential, again, if you have a just distribution of opportunity. Just for folks who maybe are not as familiar with the recovery definition and sort of a construct put forth by SAMHSA. SAMHSA really outlines 4 dimensions that support recovery. It's health, home, purpose, and community. Really purpose meaning like meaningful daily activities, meaningful work, and community participation are important for that aspect of recovery. And then community is supportive social relationships, providing individuals with love, care, compassion, and respect that they need to survive and thrive. Recovery supports really have included and involved the individual and system level approaches that foster health and resilience. And so that's why it's really important to think about, when we think about system level approaches, we have to think about these factors that govern systems, right? These factors that drive inequity within systems so that we can develop system approaches that really are effective at reducing burden, reducing the mental health burden or behavioral health burden on some of our more marginalized communities. And we think about healing. So again, just thinking about healing broadly. Alan actually mentioned again the role of trauma, or sort of where trauma plays a role in this. For people to heal, right? Just in general, to heal from what ails them, whether it's a behavioral health condition, whether it's a physical health condition, healing requires a healing environment. And when we think about healing, we think about sort of the social determinants of mental health, we have to do things to help create that healing environment. And the environment is not necessarily just limited to the social ecology of an individual, but it's really about, again, those structural drivers that create those environmental conditions, right? And so when we think about healing, how do you truly heal if we don't really cure what's ailing you? And what's ailing a lot of individuals, what drives a lot of what ails them, is what's rooted in the soil. And so that's where we have to kind of develop this social justice orientation to behavioral health. So let's chat again. So what do you think are the barriers to promoting social justice and behavioral health? Right? So throw it in the chat. What are some of the ideas that you feel like, or ideas or barriers that you can think of that are maybe getting in the way or might make it hard to promote social justice and behavioral health? Lack of training, trust, this is how it's always been. Time, giving up power, lack of training in grad school, process systems of healthcare. It's a daunting task. Time and investment of providers, lack of access, lack of cultural competence, lack of access, money, profit-driven systems, unawareness. Great answers. You sure you're all a beginning learners series? Because you have some great answers here. So good job, everyone. Fear of retribution, especially if already having marginalized identities. Absolutely. Thank you for sharing that, Marilyn. I apologize if I'm pronouncing your name correctly. Embarrassment, ignorance, apathy, outdated system policies, insurance cost barriers, lack of funds. Absolutely. Great responses. There's a lot of barriers, frankly. You all sort of outlined several of them, a lot of them. And there's likely more, right, than what we can even mention here. Unwillingness to change and willingness to see the problem. Absolutely, Lily. Cultural unawareness. Absolutely. Providing trauma-informed care, current political climate, lack of funds. Also, people know that they are unaware and ignorant and don't want to change. Absolutely. So you all, again, have outlined some really important things to consider when we think about barriers. Part of, and you all identified a lot of them. I want to just hinge on or emphasize a couple of the ones that were mentioned were also the ones I had hoped to identify here. One of the barriers is thinking that this is a complex social problem and sort of out of my wheelhouse, right? Like, I'm not sure what my role here is, so I don't really have to do anything. What I hope that you walk away from the series, so after Tuesday of next week, what I hope you walk away from the series is understanding that everyone has a role here. Just like everyone has a role to fighting racism, everyone has a role to promoting social justice. That may be in your own individual practice, that may be within your clinic, that may be within your grad school cohort, that may be within your grad school program. You all have a role somewhere to play to promote social justice. And my hope is that by the end of the series, you find maybe some of those steps that you can take. I agree that there's this idea that, we've always done it this way. We've trained great psychologists and mental health professionals. And so we don't really need to change the training that we get or change the system in any kind of way. Just because we've always done it that way doesn't mean that's how we should continue to do it, right? We have a lot of disparities to basically kind of throw and say, well, it's not really working necessarily the way that it should be, right? And so as a function, why do we continue to spin the same wheel? Right? I think we have to change things. So there is that overlying, I think, ideal, which is I'm comfortable doing what we've always done. That's kind of the space we want to sit in because it's comfortable. And I mentioned that you're going to hear me say reimagine a lot throughout the series, especially in the next two sessions. My challenge for all of you is to sort of think about reimagining the behavioral healthcare system, right? That's really what we need to do. And again, I don't expect any one person on this call to reimagine the behavioral healthcare system, but think about what you even can do in small ways, in small tangible steps that you can take to potentially reimagine your own behavioral healthcare practice to be more social justice oriented, right? We can all play a role, and we all should play a role, right? Because the soil doesn't just impact one individual, doesn't impact just one group, it impacts us all. If we think about COVID-19 was actually one of the most stark examples of when we don't take care and we don't value, we don't value, or we don't attend to the most vulnerable among us, then we're all at risk, right? So you think about COVID, it was sort of like, well, if we don't offer protections for all of these individuals, essential workers, minoritized groups, people who don't have leave, people who don't have paid leave, right? we don't offer their protection, we're all suffer. We all potentially are at risk. And so it's all about ensuring that we tend to those among us who have the most need. And if we're able to do that, then we all are in a better place. We all are safer. We all are in a better place. And our society is closer to that sort of aspirational goal of being the healthy society that we intend it to be. In behavioral health, it's the same way. If we know that the behavioral health care system is not working, or the behavioral health care as it is not working for some individuals, we have to figure out why that is. And we have to address why that is. And that can be done, again, within your own sphere of influence. But by doing that, you push the needle a little further. So maybe if you're a grad student, you push your fellow grad student, right, to think about some things. Maybe you push your advisor to think about things differently. Maybe you bring up a research question that your advisor hadn't thought about, but it would benefit learning a little bit more about structural factors, right? Everyone on this call who's a trainee, I know sometimes it can feel like you don't have a lot of power or you don't have the potential necessarily to affect change, but I promise that you do. I promise that you do, whether it's just your individual cohort or whether it's, again, your community or whether it's your institution or whether it's your neighborhood at large, whatever it is, we all have a role and we all can play a role in this. And again, I hope that that's something that you walk away from the series with. So what are we going to do? So how do we promote social justice and behavioral health? The first step starts with education, self-reflection, and interrogation. You can't do this work without really being very critical about where your role is, and frankly, upholding white supremacy and frankly, upholding racism, because we all benefit from racism in some way, shape, or form. We just do. And so that's something that we all have to sort of acknowledge and then also sort of have to be aware of. We're going to also promote norms of anti-racism, equity, diversity, and inclusion across domains of professional practice. We want to center communities in the work that we do, and we want to focus on advocacy and empowerment. So that's what sessions 3 and 4 are going to help us do. Session 3 in particular is going to be very focused on self-reflection and interrogation. So again, it's really important that you fill out, you register, which I'm going to get to in just a second. What's next? We want to ground our work in social justice, but that begins again with education, self-reflection, and interrogation. So it is Q&A time. 13 minutes. I'm on the dot here. So 13 minutes for Q&A, but in the meantime, I want to make sure that people have the opportunity to, here's my contact information if you need it. You'll see it again multiple times, but here's the GIPRA evaluation link again. Very important for us to get feedback on what you think of these sessions. It goes a long way to ensuring that NALBA can continue to do the fantastic work that NALBA does. They are an essential resource when it comes to meeting the needs of the behavioral health and mental health communities, particularly for our Hispanic and Latinx communities. So please take some time to fill out the GIPRA link after each session. In addition, in the chat, there's going to be, Priscilla will put it in or somebody will put it in, the meeting link that you will need to re-register for sessions 2 and 3. Please take a moment to do that while I start to answer questions. One, it'll just save you some time, but then 2, it'll also ensure that you get the link, the appropriate link to log into for next week. Because we're going to be starting on education, self-reflection, and interrogation, I want to make sure that folks have the opportunities to be in breakout rooms with people, with peers of theirs. So at similar training levels and or at similar, or just among trainees. So it's really important that you fill that out. So please take a moment to do that. Okay, with that, I'm going to turn it over to questions. I did that right.
Thank you, Dr. Sampilo. It was amazing. I don't see any questions on the Q&A yet. So if you all want to raise your questions, now is the time. I'm going to be more than happy to share those questions with Dr. Sampilo so she can answer to you right here in the live session. If we don't have time, or if she doesn't know the answer straight away, I know that she's going to take notes and she's going to follow up with you next week. So if we don't have questions, Dr. Sampilo, I'm going to share with you some comments. I just shared with you in a private message a comment by Mercedes in case you want to read and discuss a little bit about it. She's talking about that in some cases, leadership is also a barrier to social justice in the workplace, who turn a blind eye to mistreatment of employees at times in policies that tend to marginalize and perpetuate certain biases. I don't know if you want to comment anything on that.
Absolutely. So that's a lot of actually what my work is, my consultation work is based in, is sort of working with organizations. And one of the things that we hear is just there's not enough leadership buy-in. And I will be very frank and be very honest and say, EDI efforts, equity, diversity, inclusion, anti-racism efforts, we can push that work forward at lower levels, but there has to be a buy-in for those efforts to be sustainable and frankly valued enough to have resources and supports. And that's only going to come from having leadership buy-in in some way, shape, or form. What I try to explain to organizations that I work with when we talk about leadership buy-in and or lack thereof, how do you build leadership buy-in? There are two things. One, I emphasize why it's the right thing to do, because it is the right thing to do. At its core, it's the right thing to do, and I always emphasize that first. The second thing that I do is emphasize that there is a benefit to all organizations to adopt best practices and better practices and promising practices to reach marginalized groups more effectively. There are business bottom line reasons for that. And sometimes, even though that's not the hill like I want to like put my flag down on, that is sometimes the entry into getting leadership to think about this differently. That is not just the right thing to do, again, even though that's what I emphasize, but that there is a benefit to it. There's a benefit to gaining more market share. There's a financial benefit. There's litigation or liability, avoiding liability and litigation sort of benefits. There are business bottom lines. I'm happy to talk to you more about that offline. But when we think about sort of, for example, the national standards for culturally and linguistically appropriate services, the national class standards, which is often what I push in organizations to adopt. One of the reasons is that there's just a significant business benefit to doing that. And so sometimes I think leadership, if you get the in a way, and you have their ear, you just have to get their ear first. And sometimes that's what's get their ear. And then they kind of see the benefit. But I would say that very similar to what we just talked about, for a lot of organizations, they're accustomed to doing things a certain way and it works for them and they're comfortable. I look for the gaps too. I also say, well, there's got to be some things that aren't working as well. And then they identify what those gaps are, or sort of what the things are not working. You're not retaining your staff who are from diverse backgrounds. You're not recruiting enough staff from diverse backgrounds. Your organization doesn't look anything like the community that it serves. There's gaps. And they may be a little hesitant to identify those initially, but they will. And that's where you sort of say, okay, well, if things aren't working, again, if things are not working the way that you think that they are, or that we want them to be, then we've got to do some things differently. And I also emphasize for leadership, a mixture of obviously like big goals, big visions for restructuring, reimagining sort of their systems, but then also sort of lower hanging fruit. Like, what are some things we can accomplish that's going to get even more of their buy-in, right? So what's something that we can accomplish quickly that will demonstrate to leadership, yeah, like, you know what, this isn't going to take like a whole, this is going to take like 10 years to affect change. We can make small changes quickly, but while working towards those larger scale changes as well. I see a question in the chat. Hopefully I answered a little bit of your question. I see a question in the chat. How does that work in education systems from your experience, especially colleges, universities, and higher ed? Maybe you mentioned something along the line that I didn't pick up. So how does that work in education systems in terms of like leadership? So I would say that I don't really have experience working with sort of, well, I take that back. I don't have as much experience working with educational systems, I'll be very honest. It's more sort of behavioral health organizations that I work with. But I will say, from an educational standpoint, looking at very similar to sort of what I just mentioned about organizations in general, is there's usually a gap in terms of their service delivery. They're not reaching certain students, or certain students are not performing at their expected level. And part of that is schools and educational systems are accountable to the outcomes of their students. And so sometimes it's about, again, just like reframing the ask, or reframing sort of the importance and the emphasis of why this is important. That, again, is the right thing to do, but there are other reasons that this needs to happen. And if you can tie it back to, especially for schools, accountability measures, performance metrics that they have to hold themselves accountable to, that's where, again, your in is. Very similar to sort of organizations where they have to, for federal funding, they have to demonstrate cultural and linguistic competence, right? There's things that sort of govern that this has to be important in some way. But if you can tie it back to that and sort of enhancing or improving performance, that's sort of what you're going. That's sort of one of the lenses that you might want to go with.
Thank you, Dr. Sampilo. I think now we have time probably for the last question. We have someone, I don't know if I'm pronouncing correctly, but Tishna Lopez is asking, how would you suggest developing an effective lens of cultural competence?
Great question. So this is going to be an ongoing process, right? We're going to adopt cultural humility, sort of that idea of lifelong learning. So I think first and foremost, it's accepting and sort of acknowledging that we're never going to be, fully culturally competent, but it's sort of this idea that we're always in the spirit of learning about multiculturalism and sort of how it applies to our work, right? I think when we talk about building cultural proficiency or cultural competence, I tend to call it cultural proficiency, but I think if we talk about that, one of the things I really encourage organizations and entities to do is to get a baseline assessment of where they are in terms of their cultural competence or cultural proficiency. So there are organizational assessments, there are individual assessments, but you sort of have to know where you are to know where you have to go, right? Sort of that idea about knowing our direction. You have to know where you are currently to know where you need to go. And so I think one is starting with some measure of, generally speaking, again, it's just an estimate. It's not going to be like, this is definitely where you are in terms of your cultural competence. We're just going to give you an idea about where the gaps are. And that's something we've done here at Cleveland Clinic within our Center for Pediatric Behavioral Health. We had all of our providers fill out an assessment measure and it identified where our gaps are. Where do we need to make or place our priorities when it comes to developing cultural and linguistic competence within our providers, right? There are certain gaps that sort of emerge from that data. And data is helpful in these cases. Building the case for some of this, when you have data, you can sort of show someone like, yes, this says that we are not where we want to be. There's data to back that up. It's not an anecdote. Again, I think anecdotes are good, and in describing the need just in general is important, but a lot of people will respond to data. And so if you have data to back up the need for enhancing your cultural competence training, that's really important. I think it's also about, for trainees, because this is a trainee series, also about modeling, right? Supervisors have to model that cultural humility, cultural competence is an ongoing process. That structural competence is an ongoing process. And so supervisors, mentors, advisors, folks who are a little more senior in their career or later in their career, we have to model that. You have to model these discussions. You have to model that they don't come up just because we're talking about a patient who's from a racially or ethnically or otherwise diverse background, right? Which is where conversations about race and diversity tend to come up, right? And patient-centered sort of interactions. We have to just do that more in a more of an open forum, right? We have, we've done something here at the Center for Pediatric Behavioral Health, but we do a diversity dialogue once a month where we just talk about issues of diversity. And we just do it. It's not in the context of a case. It's not in the context of anything that necessarily is tied to even our work. We just talk about issues of diversity. And that normalizes those discussions. It models that discussion for our trainees as well as for other staff who may be a little less comfortable talking about some of these issues. But we sort of set the standard of, this is what we're going to do. We're going to talk about these issues. We're also not going to just talk about them when it comes to patient care. We're going to just talk about these issues. So we're going to have a discussion about privilege. We're going to have a discussion about racism. And we're just going to do that. And that's to be expected, right? And the more that you can do things like that, the more you can kind of build an environment that is more conducive to acknowledging your deficits or your weaknesses when it comes to some of this work, and then also acknowledging where we need to go. So I hope that answered a little bit of that. And I think we're at 2 minutes. So Priscilla, I'll turn it over to you for a wrap up.
Thank you. You did answer, because the person who raised the question just thank you for the insights on measuring a baseline to recognize the gaps in role model competency. So thank you, Dr. Sampilo. We are ending this session today. So please, I know that we have been saying this since the beginning, but if you did not yet register using this new link for sessions 3 and 4, Monday and Tuesday next week, starting at 2 p.m. Eastern time. I'm going to send you an email with a reminder, and I'm going to cancel the ones that you received previously to avoid any confusions, but I am completely available if you have any questions. On the next slide, let me see what we added here. I think is exactly what I just shared. Dr. Sampilo, if you can just move forward, please.
Oh, sorry.
Sorry.
Yep, sorry.
I just talked about this one. So the next one, just a reminder about our conference. If you are able to, we definitely invite you to join our conference. We're preparing amazing things for you in Las Vegas next month. So Dr. Sampilo is one of our presenters, so you have the opportunity to learn from her face to face. It's going to be amazing. On the next slide, you're going to see our contact information from our colleagues from the National Hispanic and Latino Ttc. And on the next slides, the contact information from the PTTC. We're completely available and happy to serve you. I hope you have a great week, great rest of your day. See you on Monday. Thank you, Dr. Sampilo.
No problem. And I just want to, real quick ending, there's not a conference that I know of that will do a concert for folks. No. So another plug to please attend this conference, yes, because they will have a concert, which is awesome. And it's a tribute to Selena and Vicente Fernandez. So it'll be fantastic. So thank you all. I appreciate you. I will see you all next week.
Yeah. Thank you, everyone. Obrigada.